I'm Dr. Anthony Levinson, one of the two iGeriCare.ca co-founders, along with my colleague, Dr. Richard Sztramko, geriatrician, both from Hamilton Health Sciences and McMaster University. And welcome to our 18th live event. Apologies for the slight technical issue. As you can see, we are not in our typical studio today due to the coronavirus pandemic. We're physically distancing from our own setups, like so many of you. So apologies in advance for the technical glitch. You missed my opening intro 5 minutes ago where I said there might be technical glitches, and sure enough, but hopefully things are back on track now. And we'd like to welcome you to a really challenging topic. The topic today we chose is long distance caregiving. And that is particularly, it's tough at the best of times if you are a remote caregiver. And now so many of us are actually remote caregivers due to the mandates around physical distancing and self-isolation. So we may not have a lot of easy answers to what is a very challenging situation, but we'll do our best to try to address some tips for remote caregiving and some specific ones that have come to the fore with the coronavirus situation. So welcome, Dr. Sztramko. I hope you're keeping safe and that you and your family are healthy.
Thank you very much, Anthony. It's a pleasure being with you again, albeit remotely. I wish the best to you and your family as well.
Thank you. Well, I think we want to start by saying that this is a rapidly evolving situation. I guess we have a little bit more knowledge and understanding on today, April 8th, 2020, than we did a month or two ago. But one important thing to start out with is, whatever we talk about today, because of the evolving nature of the situation, follow the guidelines from the Public Health Agency of Canada, your local public health units, provincial public health units, and your provincial ministries of health. And I think that's just wise because direction may change, but they're going to be providing reliable, trustworthy information to the best of our knowledge, which is, as we said, kind of an evolving situation. I guess just to start off, Richard, what are some of the general tips that you, I guess, might provide in terms of you're a caregiver at home in this novel situation?
Yeah, so I think one of the biggest issues will be changes in day-to-day routine for people. We've mentioned this before, but people that have cognitive impairment don't have the capacity, or many of them don't have the capacity to change up a routine day to day and process, novel information that's coming at them, or new day-to-day activities. So for instance, if somebody was used to going out and getting exercise at a day program on a regular basis, and now they're not able to get the exercise and they're not able to get the socialization that comes from that, and they've had the routine change, then it might cause a bit of decompensation and emergence of new behaviors. So if people aren't getting their physical activity and kind of tiring themselves out as well, it might cause problems with sleep. And so if there's an emergence of people feeling more irritable or not sleeping as well as they used to, just being more upset, easy to anger, emotional lability, it would be completely what you'd expect in this situation to be having. And, we're not able to see our in clinic right now, but we're able to see them remotely. And certainly we've noticed an uptick in the behaviors that we're trying to help people deal with at home now.
I think for many caregivers, the converse of some of those challenges too, that whereas there may have been a bit of a break or respite if the person living with dementia was going out to a day program, the caregiver is now absolutely on call 24/7 at home. Many caregivers are in that position anyway, but if there was at least a little bit of out of the house activity for the person living with dementia, like a day program, I think it also gave the caregiver a little bit of time and space to do some other tasks, for example. So.
Yeah, no, that's definitely true. I think probably the most true for people that have moderate to severe cognitive impairment and require a lot of help with their basic activities of daily living, as well as all of the higher order things like, setting somebody's medications up might not be the most challenging thing, but if you're getting them in and out of bed on a daily basis and they're having issues with continence, it becomes a lot harder. And so also this is a big, very challenging time for those people who, might have been dealing with somebody that had moderate to severe cognitive impairment and might have been undergoing a transition from their home to a different living environment or potentially long-term care. And now that's not, it's not such a great idea, or the options might not be there the way that they used to. So the high levels of caregiver burnout, we definitely expect that as well.
I think, a couple of other specific things you mentioned, normally in the past, we might have said, oh, if your loved one experiences a dramatic change and they become more confused, that could be a medical issue like a delirium or an infection or something like that. Previously, we might have said, you should go to emergency department. Now we would absolutely say, if that situation arises, you should contact your primary care provider, or if you have whoever the most responsible physician is that's looking after the person with dementia, but you should contact them by telephone or contact telehealth and not go straight directly to an emergency department to avoid potential exposure. Is that the current guidance at the moment?
Yeah, I mean, there's no perfect guidance right now that's evidence based in that realm, but definitely, I mean, an abrupt change in cognition is an emergency. So we're saying definitely get in contact with a healthcare provider, and if somebody's having chest pain and they're having a heart attack, or they've lost consciousness and passed out, or they're very unwell, certainly you still need to go to the emergency room for those things. But we've talked about behaviors previously, and there's a lot of assessment you can do before you'd send somebody to an emergency. So if somebody's really sick and you have to go, that's fine. I mean, you need your life-saving therapies or treatments administered. But if it's a slower change, or just the behaviors themselves, then perhaps getting assessed over the telephone or through a telemedicine platform would be a good first step. The other thing I was going to say too is, people might have been getting cueing from a physiotherapist that was coming into their home as well. And so, we talked about how the lack of physical activity might drive some behavioral changes or cognitive changes, but the loss of mobility as well is really problematic, because if people aren't moving around, their muscles, they're getting deconditioned, they're becoming more frail. And when that happens and the muscle strength is lost, then that means the caregiver has to provide that person with even more support.
Right.
So it's kind of a move it or lose it kind of situation where, we're saying, okay, well, make sure you keep that physical activity up as much as you can in the home, so that you're not going to have even more troubles down the line for however long as this might last. It might be a more challenging caregiving environment in the future.
And I guess that kind of activity does not have to be incredibly complicated series of exercises. That might just be not necessarily walking in place, but walking around the house in a safe way. So obviously don't go out of your way to do, dangerous stairways or things like that, but actually just getting up and moving. Walking is a good exercise. There may be other types of exercises. If you did have a physiotherapist or had been given instructions, then there might be ways to do some of those activities at home.
Mm-hmm. No, that makes sense. I'll touch base actually with the Jairus Center and see what resources they have, and we can post them in the live feed to see if there's any videos and things like that that they can provide instruction for the basic exercises in addition to walking.
That's great. The one of the other things that I think is challenging for many of us, but really important during this time, is frequent and proper hand washing. And I
Mhm.
think this is another area where extra written and verbal prompts to practice good hand hygiene are an important thing that people can do. Um, Signs with reminders to wash hands for 20 seconds, demonstrate hand washing procedures. It's hard to get alcohol-based sanitizers. Many of them are still sold out on shelves, but if you're washing properly with soap and warm water, then that is also fine, but you need to wash thoroughly. So.
Absolutely.
One of the other things that I've heard mention is uh, pharmacists have, I think, some more flexibility to do medication renewals. But if you are having, if you are, make sure you don't have a shortage of your medications, and you also don't want to necessarily have too many trips to the pharmacy. So getting extra prescriptions for a greater number of days can help to reduce the number of visits to a pharmacy.
Yeah, definitely. The less trips out of your house, the less likely you are to get exposed um, to any infections.
Yeah, and I think that's one of the realities of the situation. You may well be a spouse, you might be an older adult spousal caregiver. And if you are the primary caregiver and also doing a lot of the household duties, you're potentially putting yourself at risk by going to the grocery store or to the pharmacy. So if you have another option, a neighbor or a child who lives nearby and could help to support you, that would be a safer option just to reduce some of those potential community exposures to the virus.
Mhm.
Because many of the caregivers would be in that vulnerable age group. And I guess that's another reminder of the importance of having an alternate plan for care management if you, the primary caregiver, should become sick.
That makes a lot of sense to me. Always being proactive instead of being reactive, because when people do get sick, they can get sick quite quickly, and it's not possible to put in these backups in play. To your point about getting your medications delivered or potentially even your groceries delivered, I know it's become more challenging, just because so many people are asking for these resources now. The supply chain's a little bit
Yeah.
it's been a little bit stretched thin. So if possible, requesting the medication delivery far enough in advance so that there's still enough time to actually have that take place. And then if the medications or groceries as they're coming into the house, cleaning the actual packaging and things that are coming in, and obviously after you're done with those, washing your hands, perhaps having a dedicated place in your house where you keep all of the stuff that first comes into your house so that it's not kind of being spread throughout the rest of your house as well. That's definitely a good idea. I know there's some data to suggest that, the virus can stick around for up to 24 hours on cardboard and up to 3 days on plastic and other surfaces. So I think it is really important for people as stuff's coming through their house to be diligent about cleaning off the packaging.
We had a really good comment that just came in. This is somebody who said, my mom has severe Alzheimer's, and they were able to provide antibiotics over the phone without testing for a urinary tract infection. I guess there were maybe familiar signs and symptoms,
Yep.
and as Richard was saying, if you're able to describe the signs and symptoms that you're seeing, maybe have a remote appointment. Many family physicians are doing telemedicine through either telephones or through video conferencing platforms, for example. So that's a way that you can have an assessment, have an opinion, and potentially get access to a treatment. And they also comment that many, if not most, pharmacies can deliver. And so I think, to your point, you don't necessarily have to go out to the pharmacy, but you do want to maintain that you clean the packaging and wash your hands, like before or after handling packaging as well.
Mhm.
The other scenario that I think is, I mean, you and I have both seen people in the hospital, and that's a really tough situation right now, where if a person is admitted to hospital, they're not allowed any visitors, and so that's can be very confusing and isolating for people. But I'm wondering if you have any tips for caregivers of people living with dementia who might be in some type of like an assisted living situation, where maybe they're a bit more high functioning, like they might be in a retirement home or some setting like that,
Yeah.
but still have the challenge of not necessarily being able to have visitors.
Yeah. An assisted living facility generally is where people are living independently in their own apartments and may receive additional services to their room. So somebody might deliver medications to their room. Generally, people would pay a bit extra for those services, but we'll have some sort of central meal place where everybody eats together. And so I think drastic changes there, where people are eating now in their rooms in an isolated fashion and not getting the social programming or physical activity programming that they were before. So, we've talked a lot about social isolation and how terrible it is for both your cognition and your overall mental health. So, staying in contact with the people that are in assisted living, despite those impairments or um, uh, blocks and ability to do that is important. So whether it's just phone calls, that's a baseline, calling a few times a day. And we've talked about reorienting people that have cognitive impairment. So even with a phone call, you can provide a lot of benefit. And I would say, 2 or 3 times a day phone calls with reorientation and letting them know, what's taking place, and reminding them of what day it is and what time of year it is and things like that are helpful. I know it's pretty miraculous, and I'm sure you've witnessed this when people are really quite delirious and confused in hospital and agitated and getting out of their bed. Sometimes all you need to do is get a loved one on the phone, and it settles people down. So you think that a telephone call is not that big of a deal, but it can be a game changer. And then, if possible, video chats. Ongoing emails or text messages as well. If video chats or devices are being used, the same principles of hygiene. There may be people that require additional assistance with kind of hearing or visual assist. All of the assistance that should be done should take place in the context of physical distancing. So, making sure everything's wiped down beforehand. With sanitizing material and not getting too close to people while that's happening. And then making sure that if there are any wishes for that person, in terms of goals of care and what people want done with their medical directives. So what their wishes are in the context of getting sick are also important. Having all emergency contacts up to date as well. And the priority of decision makers for that family, so that if something were to happen, the assisted care facility knows who to call and who the decision maker will be for that person if they're unable to make decisions for themselves.
I mean, it's a very sensitive topic, but an important one around the advanced care planning. Just with the nature of this virus and older, vulnerable people, we're seeing some of the folks in long-term care homes have really gotten sick very, very quickly. So if they're, it seems it's just so important to have a plan in place before somebody gets sick. We've done a live event on this previously around consent and capacity and talked about advanced care planning. I think it was live event number 10. Just a really good time for families to try to understand, make sure they understand what the person's wishes are if they are no longer capable. But just things can happen quite quickly, whether it's the caregiver or the care partner themselves getting sick and having, as you say, here's the emergency contact information, here's our backup, primary care decision maker, but also just making sure that the person living with dementia, do they have an advanced care plan already and some advanced directives, because people can get sick very quickly with this illness.
Absolutely. The other things that are generally happening, I know this is in the long-term care guidelines. I'm sure they would be doing it with assisted living and retirement home as well, as is screening people in terms of the symptoms. So, have you had a a fever or a dry cough? There's some people though that have COVID that that have very mild symptoms. So, generally people are having, a fever, but not the majority of people. I mean, over 50% of people, but it's not like 100% of people are coming in with fevers. A lot of people will have dry cough. Some people, the minority, will have gastrointestinal symptoms. But some people might just have sniffles and muscle aches. And some people are positive for the virus and asymptomatic completely. So I think that's the challenge where the screening is really important. Definitely, if you have any signs or symptoms of an infection, you stay home, stay away from older, susceptible adults. But even if you've been traveling, obviously outside of the country, staying away from those people. If you've been exposed to anybody that has a known COVID infection, staying away. I think that's the other aspect of, limiting the visitors and keeping people out or away from these susceptible older adults.
So why don't we take a few questions, and we'll maybe come back to some other key points. Here's a question that's just come in. Is there any research about how long people in long-term care homes can go on without family support before they give up? We've been doing Zoom calls with our mother in long-term care, which is wonderful, but it's not the same as face-to-face or touch. She's quite confused about seeing all her children on TV.
Yeah, do you want to take that one, Anthony? Or
yeah, I think different people are very different. We've absolutely seen some people in the hospital who are not able to cope very well at all without family members, even if they actually have the ability to do, some kind of video conferencing. Mm-hmm. Zoom is a web conferencing platform that allows video chats. But I think different people have different thresholds for that. It sounds like you have done a great job by even being able to connect in this way. Hats off to you and to the long-term care home for persisting in this, because I think many of the staff there are sometimes it's very challenging for them. And I think many workers in long-term care homes now are kind of even more run off their feet than usual. They're short-staffed. They're now having to observe many more precautions. People are generally being fed in their rooms. So that's at least good. I don't think we have a good answer for you. I don't think there's a body of research for how long can people go on with this, but I think to Richard's point earlier, that connection, even if some of it is a bit confusing, that connection, that reorientation, seeing the familiar faces, hearing the familiar voices, I'm sure it's quite helpful, even if there are aspects of it that are, less good than face-to-face and touch. But I don't know if there's any specific research on that topic.
Yeah, I think to kind of we're talking about establishing routines too, and sometimes that takes a little bit of time. So, it might be confusing the first few times that it happens or the first week or so, but it is possible that people get accustomed to the frequent Zoom meetings. And you're right. I just echo what Dr. Levinson is saying is, um, you know, people will respond differently to it, but you might be able to establish a new routine, and people might get used to it over time.
So another really tough question, and I guess we knew we were in for some tough questions with this live event just because of the challenges. Here's one that's just wondering how we can isolate needed dementia patients. I'm wondering if this is coming from a long-term care home or a healthcare worker, or maybe somebody who does home care. Anyway, how we can isolate them. As you know, many won't stay in their rooms, wear a mask or a face covering or social distance. This is a bad situation for everyone. And I guess I would echo, I think the situation is very challenging in long-term care homes, and probably will become more challenging in some of the hospital environments if there are people with dementia in those environments. And, they won't necessarily abide by public health instructions, not just because they won't necessarily understand what is expected of them. So I don't know if you have any other suggestions on this. I think many of the long-term care homes are trying to cohort people who are COVID positive in one area to try to at least have sections of the long-term care home that are less likely to have people who are infected. Any other thoughts on that one, Richard?
Yeah, no, I think you covered it there in terms of um, the infection control side of things, and getting people together, and then just doing what you can. There's certainly a lot of COVID related delirium out there too, where people are getting acutely confused on top of their cognitive impairment, or if they had no cognitive impairment before, they're getting confused. So still using the same principles we would to manage that acute confusion otherwise, and then doing what you can around the infection control. So if the patient will wear a mask, then definitely trying to get them to wear a mask. And I guess full disclosure on that, from our point of view, we're neither infectious disease experts nor medical microbiologists or epidemiologists. So it's challenging to provide precise guidance on that.
Yeah. Here's another question that's come in. As a primary and secondary caregiver, and I wonder what to do if I have mild symptoms that could be allergies, or if the people who I'm taking care of have minor symptoms. And this is a really tough one at the moment, because we don't necessarily have testing for everybody. So as Richard said, some people do have very minor symptoms, and it might be allergies, and it might be a manifestation of a very mild COVID infection. And without widespread availability of testing, it's really impossible to know. I think you have to look at, if you have allergies, take your allergy medication and hope that relieves the symptoms, because that will be at least partially informative that it's more likely related to allergies than a COVID infection. The minor symptoms, if the people you're taking care of have minor symptoms, that's harder to know. Again, make sure that all of their medications are optimized. And then, for sure, it is still possible for people to get other infectious diseases like the common cold or influenza. We're almost at the end of influenza season here in Canada, but I was reading earlier that the US has had quite a lot of influenza cases as well as COVID-19, and it's not always easy to distinguish them. Any other thoughts on that question, Richard?
Yeah, I think the decision with those mild symptoms to go and see somebody else and provide care would be, how fundamental to them surviving are those functional requirements, and are there alternatives for other people to deliver that care, kind of like, as we were discussing before. So if you have mild symptoms and somebody else in your family doesn't have symptoms, or a friend can go in and it has
Yeah.
no risk factors, then get them to do that first. If you have mild symptoms and that person absolutely needs you there to, you know, for food, let's say, or for critical medications, then and you don't have a backup, then you have to go. And that's just the unfortunate part about this set of circumstances. But in that situation, I know Dr. Teresa Tam, the public health officer of Canada, um, has said that, you wear masks, you can wear masks out in public. I think in particular in people that even have mild symptoms, paying very close attention to hand hygiene before and after if you're going into those setups, and limiting the amount of contact then, while maintaining the physical distancing. So there's still many things you can do with respect to decreasing the risk, even if you are required to go in and interact with that person.
And I guess to clarify around masks, probably the term that's being used now are non-mask face coverings, just because there is a shortage of
Right.
medical surgical masks, N95, which are special ones for smaller respiratory particles. Which so the notion that maybe face coverings for both
Mhm.
might be indicated if there are mild symptoms. There are issues again around what do you do with those face coverings? How do you ensure that they're safely put on and taken off? Hand hygiene before and after putting on and taking off any kind of face covering. But there could be a situation, especially as Richard's saying, if you have to go out to a larger community area, there's a little bit of preliminary evidence that the face covering might help if to prevent spread. More for if you're an asymptomatic carrier, I think is
Yeah.
probably the thinking on that. So
Yeah. No, thanks for clarifying the terminology there.
mm. So there's another comment that this is good. Thank you. My question is, my father used to go to a daycare and have his bath once a week. When will this get up and running again? Lots of people relied on this amazing service. Wow. Yeah, I don't think we have the answer for that. I wish we did. I think even when sort of the immediate surge happens, let's assume and hope we're helpful with respect to the so-called flattening of the curve, trying to reduce the surge of ill patients that might need emergency and critical care. It's still a little unclear what the process of reopening some of these things are, because community infections are likely still to occur, most likely until a vaccine is available, and that is probably a year and a half until there's a tested vaccine. So very hard to know where, when, and how some of these other programs like daycares, where you might have groups of vulnerable people coming together. Yeah, I do not have an answer for you on that.
No, there are yeah, there's so much that we don't know right now. There are thoughts that a lot more of us are infected than they're thinking, just because the spread of the virus has been so quick that potentially we could all have more passive immunity just because we've been exposed to the virus, and maybe that will be protective, but nobody knows right now. So I think so. I think we're in for a bit of a longer haul here. And I mean, even in Sweden, where they're not doing the very strict social distancing for everybody across all segments of the population, they're isolating the most vulnerable, so the
Yeah.
older adults. Um, so even in that scenario, where kind of people are getting back to work, and people are being sent back to make sure the economy doesn't weaken any further, there still might be social isolation and physical distancing for the older adults,
Yeah.
unfortunately.
Here's another question. My concern is removing a family member from weekly respite visits for a CLT with early Alzheimer's. I'm not sure what that abbreviation is. This can cause extra stress, which can weaken the immune system and cause caregiver burnout on the spouse who was expecting care. So I guess this is around kind of what we talked when we first kicked off the live event, just that the reduction of respite visits, the reduction in day, adult day programs, all of that is going to have an impact on respite for the caregiver as well. So I guess I would agree with you that this change in situation, whether it's bathing, adult day programs, respite visits, like these are absolutely going to have challenging impacts on many caregivers. Are there ways, here's another question, are there ways of assessing cognition over the phone in someone we've never met before, and presuming there's no collateral or the collateral is not able to freely speak on the phone as a patient in the room with them? So, I mean, do you want to have a stab at this first? I'm going to say yes, like there's absolutely ways that we can assess cognition in an interview over the telephone. It's a little different from how we would do a sort of full clinical assessment face to face, but there are definitely ways to do it. What are your thoughts on that, Richard?
Yeah, there are. So the MoCA is one, actually. There's been some studies that have validated using it over the phone. I mean, a lot of the questions that you'd ask somebody, so, can you count back by sevens from 100? People can do that over the phone. There's a verbal form of the Trails B where you do certain tests. A few other ones I've seen being passed around are the AD8, and there are some in the Inter-RI modules as well. So one is the kind of informal testing, just interviewing people and seeing their general knowledge is and seeing what their the content of their thoughts are and how logical they are and things like that. And then, the majority of the questions on the mini mental state examination, even if you wanted to do that, the majority of them are just questions about, orientation to time and being able to recall words. And I'm sure you could hold up Pentagon and ask somebody intersecting Pentagon. So there are.
If you had the video chat, there'd be even other possibilities open up to you.
So there are the formal neuropsych tests. Some of them have been validated over the over telemedicine, and I'm sure we'll be using them in the weeks to come.
I think your point about collateral history, so getting history from a trusted family member or another caregiver or somebody who knows the person well, that would still be extremely valuable. So I think if there were a way to do that assessment and maybe set aside a time to have a separate conversation with a family member, I would say that that collateral information would also be very valuable if you were trying to look at, hey, over time, what are some of the other changes or the observed changes from the family member or friend.
That makes sense. And I mean, you don't absolutely need neuropsych testing to make a diagnosis of cognitive impairment either. If somebody has a classic slow progressing history, if you've got potentially you've had a CT head in the last year or something, and you've got all sorts of blood work, like you'd probably make your best guess and then hopefully see somebody back in 6 to 12 months time when everything's kind of settled down a little bit more.
I diagnose telemarketers over the phone all the time.
Right. Yeah.
So
the challenge in that situation is just the physical exam, not for the telemarketers, but
yes,
for patients with cognitive impairment. Yeah.
Yeah, and some of the other sort of pencil and paper tests that would be maybe more challenging. I think the other thing is administering some of the assessments at a distance could be more challenging and take longer if the person's cognitive impairment makes it challenging for them to follow the directions. So,
yeah.
Another question: How can caregivers of people with dementia communicate the COVID-19 situation and the risks involved without inducing panic or responsive behaviors? Yeah, I don't know if you have, I mean, I think this
Yeah.
is, I, I think this is a very good point. I think you have to do your best to explain what, I mean, there's still some unknowns, but I think explaining that it is a virus that is very contagious, that older adults are particularly vulnerable to infection and serious illness. And so that, that's why you can't see them, be with them. That's why social distancing is required. So I think you just have to do the best you can to explain it in ways that the person can understand. And I don't know. I think anxiety is, I think many of us, and maybe many, children and older adults are experiencing some increase in distress or anxiety, whether it'll manifest as, responsive behaviors or other types of behavioral expressions is hard to predict. But I think it's the time, the isolation, I think, is very challenging for many people.
Yeah. I think too, you know, we talk about this frequently is, does the person have mild cognitive impairment? Is it moderate? Is it severe? Because that will change how much information they could understand. And then also not kind of, what was their pre-existing personality like and how much did they
Mm.
want to know about things? What was their pre-existing educational status? So if you had a university professor that was a microbiologist, they would need different explanation and only had mild cognitive impairment versus somebody who has no science background whatsoever and is moderately cognitively impaired. You're going to change your approach based on those people. Just like, my approach talking to my 4-year-old is different than my approach talking to my 2-year-old. And not to suggest that older adults with cognitive impairment are children. You change your approach based on where people are at in their lives and their previous kind of life history.
There's another comment from somebody. There's a great resource on Dementiability website that explains what's going on for persons living with dementia. So we will check that out. And many local Alzheimer's society have home activities printable on their websites. That's an excellent point. I know our local Alzheimer's society as well is doing more caregiver sessions using web conferencing platforms. So I think many of the Alzheimer's societies have tried to adapt and create some of the offer some of the visits and sessions and workshops over the internet, which will work for some and not for everybody. So I also do want a shout out to Richard as well, because he's been part of a group doing some interesting work to expand the availability of telemedicine services to long-term care homes to try to offer more specialist consultations using virtual patient care technologies to hopefully support people living in long-term care as well as people working in long-term care by expanding the availability of consultations, which will hopefully help to keep more people safe by trying to limit their exposure going out to appointments or going to the emergency department. So hats off to you, Richard, and I want to thank you for this live event. A very challenging time for many people, some challenging questions, some of which we do the best we can, but we don't have definitive answers yet. I hope that everybody can stay safe, listen to your public health advisories, try and stay healthy, observe recommendations around physical distancing and hygiene. I want to thank everybody from the team as well. iGeriCare was developed with support from the Canadian Centre for Aging and Brain Health Innovation, or CABI, powered by Baycrest. The Jerris Centre at Hamilton Health Sciences, McMaster University, the Hamilton Health Sciences Foundation, the Alzheimer's Society Foundation of Brant, Haldeman, Norfolk, Hamilton, Halton, and our Division of E-Learning Innovation. Just a reminder, there's a donate button at the top of the iGeriCare.ca website. It would be great to be able to keep things going, maintain these live events, and continue to add to our collection of multimedia lessons. Our next live event is scheduled for Wednesday, May 27th, same bat time, bat station, 1 p.m. Eastern. You can vote on your topic. I think our leading candidate right now is genetics, but you, the voting public, can do it. I have a very high suspicion that we'll be doing it in this format again, that we're probably not back in the studio by May 27th. But I think all in all, things went relatively smoothly for the new format, and there is a survey pinned at the top of the comments section. And as always, teamwork makes the dream work, and a shout out to one of our team members who is recovering from COVID-19 at the moment. So thank you very much, everybody, and we'll see you next month.
Bye, everyone.